Dalex Pharma International is a Filipino-owned and managed pharmaceutical and medical device company with the aim to bring affordable and quality medicines in the ICU setting. Home of Dalex ICU Forum, a train-the-trainers program to raise the standard of critical care practices. Your prescription doesn't just save lives, but they transform lives to our CSR program. Care LGL and Dalex Pharma introduce NutraClear, a completely transparent neutral displacement connector that prevents catheter-related bloodstream infections. Its exclusive design guarantees that best practices are followed and ensures patient safety. NutraClear's smooth, flat septum makes it easy to disinfect. The guiding seal ring protects needleless connector's integrity. Its 2.8 cm size and 1 gram weight reinforces care comfort in neonatology and pediatrics. The neutral displacement design prevents blood reflux in the catheter. Thus reduces the risk of occlusions and infections in the catheter. Its completely transparent needleless connector ensures best hygiene practices and is recommended by experts for effective flushing. NutraClear, the closed system which guarantees neutral displacement and complete transparency to prevent catheter-related bloodstream infections. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage, according to the International Association for the Study of Pain. Pain is such an important indicator of health. Its assessment has been called the fifth vital sign, joining temperature, pulse, respiration, and blood pressure. Pain is one of the most common, debilitating, and feared symptoms of cancer. While labor pain is the most undesirable and unpleasant aspect of labor experience during childbirth, there is a need to strengthen preventive strategies for effective cancer pain management and labor analgesia, as these has the significant impact on the quality of life of the patients. Dallas Pharma International Incorporated and Smiths Medical understands these unmet needs, thus are proud to introduce CAD Solace, advancing labor analgesia and pain management care in single infusion platform. The CAD Solace system with PIB delivery along with PCA, a state-of-the-art smart pain management system for better pain management for labor analgesia. PCA, and PIB deliveries combine to create more effective drug delivery duration and block density, supports latest clinical research findings for programmed intermittent bolus deliveries. CAD Solace is a multi-therapy smart infusion for home care. CAD Solace is safe, simple, and smart, compact, lightweight pump designed for patient mobility. CAD medication cassette reservoirs are designed to keep medication safe and secure. Large screen differentiates therapies and displays infusion settings. Scroll keys help prevent double key press errors. Programming limits, clinical advisory notes, and best practice protocols. Smart pump technology promotes patient safety. CAD Solace advancing labor analgesia and pain management care in single infusion platform. You may ask our hospital representative from Dallas Pharma International Incorporated, assigned in your area with regard to CAD Solace.
Sepsis, a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis and septic shock are major healthcare problems, impacting millions of people around the world each year and killing between 1 in 3 and 1 in 6 of those it affects. Shock is common in critically ill patients with COVID-19, developing in up to 67% of patients in intensive care, and is associated with high mortality. In the recent guidelines issued on care of critically ill adult patients with COVID-19, norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. But sepsis and COVID-19 do not only affect the health of the patient. Sepsis and COVID-19 can cause financial burden and has an impact in the environment as well. Although there are positive effects brought about by the lockdown, there is a growing concern in the increasing medical waste generated from hospitals and public's use of disposable safety equipment. Brought about by sepsis and COVID-19, there is a need for an ideal norepinephrine solution to manage hypotension due to shock to achieve mean arterial pressure greater than 65 mm per mercury. A cost-effective norepinephrine to help alleviate financial burden, a norepinephrine that cares for the environment. Norepin is an ideal norepinephrine solution based on clinical studies and guidelines. Norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. Norepin passed the Institute of Pharmaceutical Sciences National Institute of Health in UP Manila with an assay test result of 106.7%. Norepin is cost-effective compared to the Innovator brand and can provide a savings of up to 23,000 pesos. Norepin 10 ml preparation can cut the number of ampules to be opened by 40% compared to the Innovator brand. Thus, it helps lessen the medical wastes. Moreover, Norepin 10 ml preparation has the following advantages. Be a part of our CSR advocacy and world vision. Your prescription doesn't just save lives, but transform the lives of these children in world vision. Every time you request Norepin at the pharmacy means sending a child to school and help fulfill their dreams.
Pain is the most common reason people seek medical care. In the postoperative period, 80% of individuals suffer from postoperative pain, with almost all describing it as moderate to severe. The ERA's protocols recommend the use of preemptive analgesia and NSAIDs as postoperative analgesic to decrease opioid requirements. NSAIDs are also proven to be effective in the management of acute pain with an inflammatory component and as part of multimodal analgesia. But not all NSAIDs are the same. For better pain management, use an NSAID that is safer, tolerable, and effective. Studies proved that ibuprofen's adverse effect profile is better since the COX-1 and COX-2 ratio is lower. This is the reason why ibuprofen has been rated as the safest conventional NSAID. In a meta-analysis where the gastrointestinal risks of 28 NSAIDs were compared, ibuprofen possesses one of the most favorable risk profiles at 1.8 compared to diclofenac at 3.3 and ketorolac at 11.5. Ibuprofen was also found to be one of the molecules with low cardiovascular risk. There were initial concerns about the safety of people with COVID-19 taking ibuprofen. The WHO conducted a comprehensive review of 73 clinical trials on the safety of NSAIDs for individuals with COVID-19 in 2020. They found no evidence between taking NSAIDs and severe side effects, reduced recovery times, or death in people with the disease. A more recent study in the United Kingdom also found no evidence of an association between NSAID use and a higher risk of death or more severe illness in those with COVID-19. IV ibuprofen also reduces opioid doses. In a clinical study, patients treated with IV ibuprofen used 31% less morphine following orthopedic surgery. IV ibuprofen's efficacy is evaluated in this Oxford League table where the number needed to treat or NNT values of various analgesics are compared. Ibuprofen 800 mg and 400 mg have lower NNT values of 1.6 and 2.4 respectively, compared to other analgesics. Intrafen is the first and the only IV ibuprofen in the Philippines. Ibuprofen, Intrafen, has 3-in-1 benefit. The pain-relieving properties of Intrafen relate to its central and peripheral effects. Apart from being an effective postoperative analgesic, ibuprofen, Intrafen, is also good in preemptive and intraoperative analgesia. So, for better pain control, use an NSAID. That is, safer, tolerable, and effective. Use ibuprofen, Intrafen, a classic ibuprofen reinvented.
Please take note of the Zoom reminders. When joining the webinar, please secure a stable internet connection to avoid being logged out from the webinar. All questions will be entertained after the presentation. You may type your question in the QA box so that the moderator can take note of it. Do not leave the webinar session without answering the evaluation form. Link will be posted in the Zoom chat box. It expires in 72 hours. Thus, an attendee needs to answer before the expiration date of the evaluation. The e-certificate will be issued and sent to the attendee's email within 7 to 15 working days for those who registered and attended via Zoom. An attendee will only avail of an e-certificate if he or she stays at the webinar session for not less than 60 minutes.
Our Heavenly Father, the fount of all goodness and grace, the cause of wisdom, the source of intelligence, we welcome you, O Lord, to this auspicious gathering of your beloved, who continuously give you thanks for every opportunity to learn something new and become fruitful to the works of your creation. We humbly come to you, not because we are worthy, but because we find ourselves in need of you, who is our strength and our hope, to continue despite the challenges we face in health, prosperity, and our solidarity with one another. We pray that today's gathering, made possible by the grace of advancements in technology and social media, becomes successful in its endeavors, so we can offer it back to you as our humble offering to honor you, glorify you, and love you through our deeper connection with everyone. May we find bliss in today's session and become more productive children and co-creators of the earth. This we ask and pray through Christ our Lord. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Bayang magiliw, pero sa silanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupi, di ka pasisingil, sa dagat at bundok, sa simoy at sa langit mong bakaw, may nilang ang tula at awit sa paglayang minamahal, ang kisap ng watawat mo'y tagumpay na nagdidinig, ang bituin at araw niya kailan pa may magdidilig, lupa ng araw ng walang pagsikat, buhay ay langit sa ating mo. Aming ligaya dapat may mga aking ang namatay ng dahil sa'yo.
Here is our Senior District Sales Manager of Delix Pharma International Incorporated. Let's all welcome Mr. Carl Angelo Lim.
On behalf of Delix Pharma, I would like to thank the Manila Academy of Regional Anesthesia for collaborating with us for the CME endeavor on POCUS Spotlight, Airway, and Gastric Ultrasound. To our invited speakers from Canada, thank you for your desire to impart your expertise to our Filipino participants. And to our wonderful attendees this afternoon, we are sure that all the learnings and knowledge you will gain from this session will be instrumental to your profession in managing your patients. Delix Pharma would like to take this opportunity to reinforce its critical care medicines and medical devices to support healthcare professionals meet the gaps in critical care with quality and cost-effective power brands such as Norepin, Norepinephrine, Nicardelex, Nicardipine, Intrafen, Ibuprofen IV, Ifimol, Paracetamol IV, Totilac, Hypertonic Sodium Lactate, Axazolid, Linezolid, and NutraClear, Needleless Connector. We are bringing hope to the lives of every critical ill patient. And please note that every time you use the Delix product, you don't just save lives, but you also transform lives of less fortunate children to our various CSR programs, such as World Vision, the Jeepney for a Cause, the LC Gatches Village, and feeding program in partnership with DepEd. Thank you, and please enjoy the session.
To give the opening remarks is the Chief Division of Regional Anesthesia, University of the Philippines, Philippine General Hospital, the Chair of Academic Committee, Manila Academy of Regional Anesthesia, and the Vice President of Philippine Society of Anesthesiologists. Let us all welcome Dr. Pinafrancia C. Cano.
Good evening to everyone in the Philippines and the rest of Asia, and good morning in Canada. Wherever you are coming from, on behalf of the Manila Academy of Regional Anesthesia and Delex Pharma, we would like to give you all a warm welcome. The webinar for today is special because we have with us two speakers, namely Dr. Vincent Chan and Dr. Anahi Perlas, who are very well respected, very well recognized, and who are an authority not only in regional anesthesia, but also in point-of-care ultrasound. I have known both of our speakers when I was just starting to learn ultrasound-guided regional anesthesia. I had several encounters with both of them during ASRA meetings, RA congresses in Asia, and then lately also in POCUS meetings, which is organized by the ASRA POCUS Special Interest Group, which Dr. Chan and Dr. Perlas co-founded, of which I am also a member. Today and in the next coming months, Mara will conduct webinars on POCUS, which is essential in the practice of anesthesiology. Airway management is a critical skill, and over the years, mounting evidence has shown an increasing role of ultrasound in airway management, which can benefit both the provider and the patient. In fact, it is probable that it will become the first-line non-invasive adjunct assessment tool in airway management. On the other hand, a reliable method of assessing gastric contents is currently lacking. Based from the report of the Royal College of Anesthetists last 2011, aspiration was responsible for 50% of anesthesia-related deaths. Relative to this, gastric ultrasound has an emerging role in assessing peri-procedural aspiration risk prior to the induction of anesthesia. With the lectures that we will be having for today, I hope this will serve as an eye-opener for us to learn this new skill. Without further ado, let me now turn you over to our moderator for today, Dr. Noel Aipa, who is currently the head of the Regional Anesthesia Fellowship Program at the Makati Medical Center. He is also one of the pioneers of ultrasound-guided regional anesthesia in our country. He is also a co-founder and faculty of MARA. He also has a special interest in the airway point-of-care ultrasound. May I now call on Dr. Noel Aipa.
Yes. Thank you very much, Dr. Acano, for that wonderful introduction to our speakers. Now, our session for today, I would like to first welcome everybody to another edition of MARA's continuing effort to deliver quality service through educational webinars on regional anesthesia. But as for today, as was mentioned by Dr. Acano, as a special thing, we'll veer away from RA, but we'll delve into that wonderful and intriguing topic of point-of-care ultrasound. Our speakers for today not only represent the practice of the use of ultrasound for nerve blocks, pain interventions, but also for point-of-care procedures. They are the embodiment of the collective knowledge acquired throughout the years, as evidenced by the voluminous data they have achieved pertaining to them as founding members. To use the word summarize with their voluminous resume, with regards to their achievements and portfolio will not be justifiable, so let me try to zero in on relational data pertinent to our discussion and webinar for today. To introduce the first speaker, our first speaker, I am very proud to introduce Dr. Vincent Chan, presently the Director of the Faculty Development of Anesthesia in the Faculty of Medicine, formerly the Head of Regional Anesthesia and Pain Program, and ranked Professor and Active Staff of the University of Toronto in Canada and the Department of Anesthesia, University Health Network. He is the receiver of numerous prestigious distinction awards such as the Distinguished Service Award in 2017, Carl Koller and Gaston Labat Awards in 1998 and 2016, given by the ASRA and the European Society of Regional Anesthesia. He's an FRCA Fellow by election of the Royal College of Anaesthetists in the UK, Professional Achievement Award and Gold Medal Award given by the Canadian Anesthesiology Society, and a lot of other awards such as Teaching Award for Achievement in Education, International Anesthesia Research Society, and the Continuing Medical Education Development Award, given by the Mount Sinai University Health Network, Department of Anesthesia and Pain Management. Presently, he is an honorary member of the Romanian Society of Anesthesia, the Royal College of Anaesthetists, the American Society of Anesthesiology, the Royal College of Physicians and Surgeons of Canada, the American Society of Regional Anesthesia, the Canadian Anesthetist Society, and other very, very prestigious boards and societies worldwide. He is the immediate past president of the American Society of Regional Anesthesia and Pain Medicine, and the board member of the American Society, service board member of the American Society of Regional Anesthesia and Pain Management. He has functioned in editorial boards of the Anesthesia Analgesia, Anesthesiology, RAPM, Canadian Journal of Anesthesia, as well as the Australian and New Zealand College of Anesthetists Reviewer, to name a few. He has published more than 300 peer-reviewed journals in regional anesthesia, point-of-care ultrasound, and pain management topics, and has been invited as speakers so many times in venues such as this worldwide. Here to answer the question, can ultrasound be visualized? Can ultrasound be used to visualize the airway and be safely used as a tool for intubation? It is with all pride that I welcome Dr. Vincent Chan for his application of airway ultrasound lecture. Dr. Chan.
Hello everyone. A very early good morning to you from Toronto and a good evening at your local time. This is Vincent Chen from University of Toronto, Canada. I'm very glad to participate in this Manila Academy of Regional Anesthesia webinar on the topic of airway ultrasound. I am going to talk about the indications of airway ultrasound to give you a brief review of the sonoanatomy of some of the basic airway structures, and then to go over some of the clinical applications. The use of airway ultrasound, or the learning of airway ultrasound, is actually quite simple among all the point-of-care ultrasound applications. So it should not take you long to acquire the skills to see these structures, since airway structures are usually quite superficial and easy to see. I have no conflict of interest to disclose. The ultrasound of the airway has, there are many articles already published in the literature. The one that you can actually go back way back to 2003 by Love. This is a nice pictorial review of the topic even to this day. Also, you will see a number of articles by Dr. Michael Christensen, who is a Danish anesthesiologist. He has done a number of studies and written a number of reviews on this topic. Our group has also done quite a number of studies and written a few articles. We first look at the sonography of the airway structures. Then we go on to compare ultrasound with CT scan as an imaging tools for assessment of airway structures. And finally, we look at ultrasound and see whether it is a valid and reliable imaging tool for airway evaluations. Most recent one, published last year, is airway ultrasound in critically ill patients. And you will see that the pictures is also another nice review, but the pictures are not that different from any others. So really there hasn't been a major advancement in airway ultrasound so far. As with any point of care ultrasound application, we use the I-AIM framework. I stands for indications. Why do we use airway ultrasound? What specific information are we trying to get from this application? Number 2, A is acquisition. We need to learn how to position a patient, know which type of probe to use, and then to acquire a good image. Remember, anything with ultrasound, a bad image would give you no good information. The next I is interpretation. Based on what we see, what can we derive? How do we interpret the image? Usually for airway ultrasound, we see superficial airway structures, either is cartilaginous structures, bony structures, soft tissues like the tongue muscles, glandular tissues, and then one very specific characteristic of airway ultrasound is commonly see the air mucosal interface. So this is a very bright line separating the air from the mucosa. Finally, based on the information we gather, we hope that the ultrasound of the airway can give us some information. Usually is to guide your treatment, guide your intervention. So if you look in the literature, you see a whole host of indications. I listed 9 here for you. As far as I am concerned, I find 3 of them are most relevant, most useful. One is to predict the size of endotracheal tube, particularly in pediatric population. Number 2 is to use it to guide percutaneous dilatational tracheostomy, mainly in the patients with a difficult airway, meaning maybe morbidly obese with difficult landmark. Third is to mark the site for cricothyrotomy in case of emergency. I don't advocate to use airway ultrasound to mark the site for patients with normal neck anatomy, but this will be highly useful when a patient has a difficult airway, meaning the neck is swollen, the neck is thick, the landmark is not easily palpable. This is a very useful tool to use. Now, all the other applications I put down questionable. Many of them can be done, but the question is, would you use it in emergency situation? And some of them are still in the investigational phase. So for example, to predict difficult airway, now I would say that if you worry about anterior larynx with the video laryngoscope, it's not really a challenge anymore. If you really worry about the endotracheal tube placement in emergency situation, I doubt that you will get an ultrasound. You would rather do a direct visualization method. We would never be as good as the ENT colleagues to diagnose airway pathology, so I leave it to them for this application. To assess obstructive sleep apnea, this is still an investigational tool. Right now, our center is looking at this right now, but it's not clearly defined. You can use it to help with airway nerve block procedures such as the superior laryngeal nerve block. But personally, I very seldom would do it. And finally, predict whether there will be post-extubation stridor, whether the extubation will be successful. Again, this has been written, but I don't think that many people will use it. So acquisition. Usually what we do is we put the patient supine with the head extended. You can use a linear probe, a high frequency probe, or a curved probe. The advantage of a linear probe is all these structures are superficial, so you will have a good image, image with good resolution. As opposed to a curved probe, the advantage is you have a wider field of view. You can one image would show you structures extended for a large area. So you can image in a longitudinal fashion or transverse. So those are 2 ways of scanning. I find that the hyoid bone is very helpful. I use it as an important bony landmark. You can scan above the hyoid bone or below the hyoid bone. If you scan it above the hyoid bone, you can see many structures that are submandibular, the submandibular glandular structures, but also a large part is the tongue, the muscles of the tongue. You may also see the palate, but it's very difficult to see the back of the pharynx. The rectopharyngeal space is difficult to see because there's a column of air in between. Now, if you really want to see the palate and you may not see it well, all you need is to eliminate the column of air by asking the subject to keep some water in the mouth, and then you'll be able to see it. Remember, air is the enemy, so anything that is hidden posterior to the column of air, you will have a hard time seeing. If you scan it below the hyoid bone, you will see many cartilaginous structures, the thyroid cartilage, the cricoid cartilage, and the cricoid rings of the trachea. And through each of these cartilage, you may see the internal structures, the lumen of the larynx and trachea. Again, you will see a lot of air artifact. So this is an example of a transverse scan above the hyoid bone in the submandibular level. You will see the muscles of the tongue, the mylohyoid, geniohyoid, genioglossus muscle of the tongue. You will see the surface of the tongue, and you have a glimpse of the palate uppermost. You can also scan it longitudinally. Here you see a good view all the way from the mandible, the bony structure mandible, all the way down to the hyoid. Again, you see the layers of the tongue muscles and the surface of the tongue. Now, this is what is important here is you also can see the the base of the tongue that is deep, that you usually cannot see on the inspection. Then as you move down lower, so this is right at the level of the hyoid bone using a linear probe, a high resolution. You see that the hyoid bone is a U-shaped, curved bony structures. If you follow it more laterally, you will see the greater conure of the hyoid. So this will be a good landmark for superior laryngeal nerve block. If you move down below the hyoid bone, above the thyroid, this will be the thyrohyoid membrane, and through this membrane you can see some characteristic structures. On each side you see the strap muscles, and then in the midline you will see a very hyperechoic soft tissue mass. This is the pre-epiglottic space. Then you will see a hyperechoic line. This is the air mucosal interface. The air is on this side, and this is where you expect to see the epiglottis. You may not see the epiglottis well because the epiglottis is suspended in air. So if that is the case, you may not see it unless it is swollen. When you move down to the next level, that's the thyroid cartilage. In male is a very sharp V, in a female is less curved. Right? So this is very easy to recognize. Very superficial. The thyroid cartilage is oftentimes not ossified, so the ultrasound beam can penetrate and you can see the movement of the vocal cord. What you see here is the movement of the fourth cord. When you say la 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 or deep inspiration, expiration, you see the movement of the fourth cord. When you go down to another level, that's the cricoid cartilage. The cricoid cartilage is the biggest cartilage in the larynx, and it is certainly easy to find. You can, with the transverse view, you can appreciate the curvature of this ring, the cricoid cartilage ring. And through that, you can see the cricoid cartilage, which is the thickest of the cartilaginous ring. The ultrasound beam can penetrate cartilage. That's why you see the air mucosal interface. This is air artifacts in the lumen. You can also appreciate the curvature of the cricoid cartilage, and you can determine the transverse diameter of the cricoid cartilage. So this is a view of the cricothyroid membrane. This is not cartilage, this is soft tissue, and here it is a cartilage. Here is a subtle difference. I find that it's easiest to find the cricothyroid membrane by the longitudinal view, because when you do this, you can see the thyroid cartilage high up. You can see the cricoid cartilage lower down. In between, it got to be the cricothyroid membrane. And you see the air mucosal interface. So what I usually do is I go down to the trachea. These are the cartilaginous ring of the trachea. I move up. You will see a big cricoid cartilage, and you move up further. You will see the cricoid cartilage, and the high up the thyroid cartilage. In between is the cricothyroid membrane. When you do the scan, I don't put the probe right in the middle, because the thyroid cartilage is quite prominent. I usually just move it slightly to the side, and you can get a good view of the membrane. As you move down to the trachea, through the thyroid gland, you can appreciate the thyroid gland on each side is white, is homogeneous. There you may find some thyroid lesion incidentally. Again, you appreciate the tracheal ring, the cartilaginous ring, the air mucosal interface, the lumen of the trachea filled with air artifact. The next important structure you should recognize is the esophagus. The esophagus is hiding between the trachea on the medial side, thyroid superior anterior to it, and then the esophagus is in front of the vertebral body. So it's sandwiched between these structures. And it's easier to see on the left side than the right side as you ask the patient to turn their head on to the one side. You can also ask the patient to swallow, and when you swallow, you see the air. Sometimes you just see fluid coming through. You also appreciate the wall of the esophagus very easily. So after giving you a brief review of the sonal anatomy of the airway structures, then we need to ask, what are the relevant clinical applications? Again, as far as I can say, is the most important application to us as anesthesiologists, I believe, is to mark the cricothyroid membrane, the site where you would do an emergency cricothyrotomy in patients who have a difficult airway anatomy. Right? So our emergency colleagues have done a number of studies using cadaveric models. They can show that, it is actually useful, and I have no doubt it is useful. But I think the most useful, most important for us is when the patient has a poorly defined neck anatomy, whether it's swollen, whether a patient is really obese, has a thick neck, or a patient has previous radiation treatment or surgery there. This is the time you may want to use the ultrasound to locate the cricothyroid membrane. Before a cannot intubate, cannot ventilate situation, you mark it ahead of time. So again, I usually put the probe slightly off midline so that I can get a good image of the two cartilage structures, and then in between the cricothyroid membrane. Another trick is to simply use either a metal stylet or a paper clip. As you roll the stylet or paper clip down, you will see an artifact coming down, and this is where you can mark the cricothyroid membrane. Let's do it again. As you come down, you can see the artifact from capsulet. you can see that this is the artifact of the stylet, and once you are there, then you can mark it. You can now mark the site for the cricothyrotomy. Again, I don't advocate we use this on patients who have normal neck anatomy. Usually palpation method is very easy to do. Another simple method is when we do a weak fibroptic intubation, you won't need to topicalize the trachea. You simply put a needle in. You simply put a needle in and you aspirate. When you get free flow of air, you know you're in the right place. So there's no surprise. But it's good to practice how to outdo the ultrasound of the airway in a normal patient with normal anatomy, so that you know what to do when it's difficult. So this is one example, a case report of someone who has an abscess, in a large neck abscess pushing the trachea to one side. It's difficult to palpate the cricothyroid membrane. So this is a very useful time to put on the ultrasound. Another case report of using this to look at the integrity of the cricothyroid membrane. When it's a trauma situation, you see a disruption here. So you can again recognize something is wrong. You can also use it for airway nerve block, right? I'm starting at the level of the hyoid bone. Again, seeing that the greater conure of the hyoid bone, usually we just before ultrasound, we just palpate and then inject there. There you want to block the internal branch of the superior laryngeal nerve. Another method is with ultrasound, you can now see the thyroid hyoid membrane, and there you know the internal branch of superior laryngeal nerve will penetrate this membrane, and this is also another site that you can inject your local anesthetic. Usually the superior laryngeal artery goes with the superior laryngeal nerve, and this will be a good way to find the nerve. Again, I'm not an expert in doing this block. I very seldom do superior laryngeal nerve block myself. Then there is also a point of care examination of the airway when someone have epiglottitis. I told you that if the epiglottis is not swollen, it may not be easily seen, but in this case, a patient has an enlarged epiglottis, so you see the pre-epiglottic space, and now this is the epiglottis swollen, and this will give you an indication that yes, the patient is in trouble. Oftentimes, after thyroid or parathyroid surgery, the surgeon will ask you to check if the vocal cord is moving or not. They worry about injury to the superior laryngeal nerve. So you can use ultrasound, you can use Doppler. If the left side of the vocal cord is moving, you can see the artifact. The right side is not moving. But today, our surgeon is using their own monitor, the nerve monitor, real time, to avoid the superior laryngeal nerve injury. So this really is not commonly done in our center anymore. Next is any swelling of the vocal cord after someone has prolonged intubation. In the ICU, you ask, would the patient develop post-extubation stridor? Would the extubation be successful? So some people will look at the column of air, the shape of the column of air. So when this is in a normal situation, the vocal cord is not swollen. When the cuff is inflated, you can see this like a square column of air. When the cuff is deflated, you expect that more air can go through. The air column has changed the shape, now is a trapezoid. So this is normal, what you should see. If the vocal cord are swollen, you will see there's no change, whether it is inflated or the cuff is deflated, you still see the same, there's no more trapezoid. This application has been studied a few times, and this is another one to look at the laryngeal edema. They find that when the air column width is less than 1.6 millimeter, it is therefore a narrowing. There is evidence of swelling, there is narrowing of the air column. Next, I think maybe of great interest to the pediatric anesthesiologist is, instead of using a formula to calculate the endotracheal tube size, you can now use ultrasound. It tells you the transverse diameter. Studies have shown that ultrasound measurement and MRI measurements correlate to each other very well. I found a few case reports. This one recently is an unexpected subglottic stenosis in an infant. They find that they are able to choose a tube that is only 2 millimeter in diameter for intubation. To compare ultrasound with endoscopic examination, you can see the AP diameter of the trachea is very well correlated between the two methods of assessment. Then in patients who is really morbidly obese, it's difficult to find the second and the third tracheal ring for the percutaneous dilatation tracheostomy. So this again will be a useful application. Someone asked if ultrasound is helpful to detect difficult intubation. And again, I find that there are a number of studies. All I notice is people are just looking at the soft tissue thickness at different level, whether it's hyoid bone or the thyroid membrane level, just to see, or the vocal cord level, just to look at this distance. Obviously, the thicker it is, they think is more difficult to intubate. Perhaps the larynx is more anterior, but again, with video laryngoscopy, I really don't think it's that helpful. Of all the methods examined, I think the one by Dr. Ben Sui makes most sense, just to look at the pharyngeal and laryngeal axis and whether they are alignment. So his method is useful, but I don't think it will be very practical, because very few people will be willing to put a small curved probe in the mouth, under the tongue, to do this sublingual view. So what he's saying is that if you can see the hyoid bone with this view, you know it is not anterior larynx, and it should be easy to intubate. So since for the sake of science, I put this in my mouth, and this is the hyoid bone. So since I can see it, I know I'm not a subject of difficult intubation. Okay, confirm endotracheal intubation. I think the question is why would you need it? I think if someone who is difficult to the larynx is too anterior, or there is a lot of tissue you cannot see, maybe ultrasound is helpful to confirm placement. Or someone has arrested, there is very low pulmonary flow, you are not in the operating room, so you don't have CO2 monitor, and also you don't want to intubate. You don't want to ventilate after the intubation. So how can you tell? Well, you can tell by seeing whether the tube is in the esophagus, right? If the tube, this is the esophagus here, if you put the probe and then put the tube in the wrong place, the tube is now in the esophagus. So now you have a double track sign. This is a trachea in the midline, and you see something like the trachea on the side, the double track sign. So there's a tube in the esophagus. Or another method is called the tracheal dilatation test. And it's one test that has not been validated, but I've tried on a few patients and it seems to work. all you need to do is to scan above the sternal notch, and as you scan up, as you inject about 8 mils of air in, you can see the stretching of the trachea diameter, so you know you're in the right place. I've done this, and this actually is a bit noxious. When the patient is not paralyzed, the patient may react to this tracheal dilatation test. And finally, in this illustration, the anesthesiologist put some saline into the balloon and inflate, and you can also see some signs that there's movement. So you know the tube is in the trachea. But if you are willing to ventilate the patient, then look for signs of ventilation. Some people will look at the lung sliding, see the pleura and the fine movement of the sliding. I find this is not as easy to see as opposed to a gross movement of the diaphragm. So what we're talking here is simply put a linear probe on the side of the chest wall, on the left side and the right side. And what you're doing is you put the probe at this area where the diaphragm is curved down next to the chest wall. This is called the zone of apposition. This is the liver. As the inspiration, the pleural line will come down. This is the diaphragm. The diaphragm will be thickened. So for sure, there's a gross movement of the pleural line. You know there is ventilation on this side. You can check similarly on the other side. Finally, we are at our center. We are now looking at obstructive sleep apnea and see whether this tool can add and more specificity to stop bang questionnaire. And what we find is that there is some suggestion to say that the distance between the mandible and the hyoid bone and the upper airway length between the hard palate and the hyoid bone, and also different measurement of the tongue thickness, give you some idea of the severity of obstructive sleep apnea. So these are all the applications that I have summarized. In my opinion, the most useful ones are the three. From someone with a difficult airway, mark the site of cricothyroid membrane for emergency cricothyrotomy. Second, for a pediatric population, particularly of someone with subglottic stenosis, use it to determine the size of the endotracheal tube. Third, in someone with a difficult thick neck, this can guide percutaneous dilatation tracheostomy in the ICU. I put these as somewhat helpful. It certainly can help you with the airway nerve blocks, confirm endotracheal tube placement, and successful extubation. Maybe there's a role, but in an emergency situation, I think you rather look yourself and not grab an ultrasound machine. And finally, these are probably least helpful, or the sleep apnea is only investigational phase. So this is all I have to say. Thank you very much again for inviting me to talk on this topic. This is my email address. After the Q&A period, if you have more questions to ask me, please email to me. Thank you very much.
Thank you very much. That was very informative and teeming with interesting facts, Dr. Chan. Thank you for the eye-opening lecture in airway ultrasound. And I'm sure a lot of our participants are raring to try it out in their respective hospitals and their practice. But before we let them do so, here's another topic that would boggle your senses and stimulate your learning capabilities as we move on to the next lecture of our speaker on gastric ultrasound. Our next speaker, Dr. Anay Perlas, is a tidbit of her name. Her name in the local Filipino language means pearl, because she's really a gem of a practitioner focusing her expertise and being known through her works in publications and research worldwide, not only in regional anesthesia, but also in her pioneering works in point-of-care ultrasound. She is presently a staff anesthesiologist, the Department of Anesthesia in Toronto Western Hospital, the University Health Network, as well as a professor and lecturer in the Department of Anesthesia. She has garnered so many prestigious awards in topics pertaining to regional anesthesia and POCUS from 2002 until the present time. Aside from being a member of ASRA, the Canadian Society of Anesthesiologists, her pioneering works as founder and co-founder of the POCUS ASRA Special Interest Group has catapulted her to the fame status that she is in right now. She also headed numerous workshops and webinars in Toronto Western Hospital. She also functioned as editor of the RAPM, the Regional Anesthesia and Pain Management Journal, the Journal of Ultrasound in Medicine, Acta Anesthesiologica Scandinavica, and the Canadian Journal of Anesthesia. You know what moved me as I read through her resume is her mention that her main focus is the enhancement of patient safety by developing and validating perioperative ultrasound applications, as since 2002, has described and studies several techniques on ultrasound-guided PNB and central neuraxial blocks, new techniques, and investing efficacy and safety through numerous clinical trials. In addition to that, since 2008, she has led a multidisciplinary group from the field of medicine, medical imaging, surgery, and gastroenterology in the development of a point-of-care ultrasound protocol to evaluate gastric content and guide anesthetic management at the bedside, defined and validated a standardized imaging protocol, and established its diagnostic accuracy and reliability, and defined its use in various patient populations, such as the adult, pediatrics, obstetrics, and the severely obese. Her works as an expert has published more than 150 peer-reviewed journals, garnering more than 4,000 citations, as well as authored chapters in books that expresses and presents her authority on topics of expertise. She has conducted more than 100 lectures and workshops, mostly on RA and POCUS. Among the works that have rendered her recognition are her editorial works in point-of-care ultrasound, and presently a member and lead for the Gastric Ultrasound Workshop Group. Here to marvel us on how ultrasound takes a peek on the stomach and its contents, and its value not only to anesthetics but to the multi-specialty practitioners as well, let us all welcome Dr. Anay Perlas.
Thank you very much for the kind invitation and for the lovely introduction. The topic for today is the use of perioperative gastric point-of-care ultrasound. I do not have any financial relationships with any commercial entities to disclose. I would like, however, to acknowledge the support of a number of professional organizations for my work, including the Canadian Anesthesiology Society, the Anesthesia Society of Anesthesiologists, the Anesthesia Patient Safety Foundation from the United States, as well as the Physician Services Incorporated Foundation from my province of Ontario, and my colleagues at the University of Toronto and the Toronto Western Hospital for their tremendous support of my work over the years. Of course, when we consider using a point-of-care gastric ultrasound, it's because we are concerned about the potential for pulmonary aspiration. This is an anesthesia-related complication which is still quite prevalent despite many advances in anesthesia in general. This is an area in which we have not advanced very much in the last 2 to 3 decades. This particular study, the NAP4 study from the Royal College of Anaesthetists from the United Kingdom, is a review of all cases that ended up in fatality related to airway management back in 2011. And at that time, they found that the number one cause of death from airway-related events in anesthesia was, in fact, pulmonary aspiration. It was not the inability to establish an airway, but rather pulmonary aspiration as the number one cause of death. Of course, this may cause serious morbidity as well as death. And in many of these cases that ended up in fatalities, they found that the assessment of aspiration risk had been inaccurate. In other words, the tools that our colleagues had to determine whether this patient was at risk of aspiration or not were relatively limited. This recent publication in anesthesiology identified all close cases of medical legal claims in the last 2 decades of practice in the United States. And it's not surprising to see that they found, of course, most of the outcomes were very serious outcomes, and that's natural given that these were medical legal cases. About over 50% of the cases, 57% of the cases ended up in death, in the patient death, and about 14% in serious permanent injury. But what it was a bit surprising to me is to see that all types of surgeries were well represented in this sample. In fact, we usually think that aspiration is not that common in elective surgeries, but in fact, over 50% of the cases that ended up in medical legal action here, 55% of the cases were related to elective surgical procedures and 45% related to emergency surgical procedures. So this can really happen in any of our surgeries to any of our patients. We have very good fasting guidelines from the American Society of Anesthesiologists. These are important guidelines that we use on a daily basis. We are all very familiar with them. We know that it's safe to fast for 2 hours for clear fluids prior to elective surgery. For a light meal, it's recommended that the patients fast for at least 6 hours. And a light meal is defined by these guidelines as tea and toast. And in the case of a fatty solids, a full meal, like a full lunch or a full breakfast or a full dinner, then they recommend a minimum of 8 hours of fasting. And they have specific recommendations for pediatrics depending on the type of milk. Now, these guidelines are very important. They're very useful. They are key to our patient safety, but they have their limitations. And the main limitation is that they're only applicable to healthy subjects undergoing elective procedures. In other words, if you have patients that even though they may have fasted, but if they have very serious comorbidities that may delay their gastric emptying, such as very severe diabetes with diabetic gastroparesis, end-stage renal disease, severe liver disease, or they're coming for an urgent surgical procedure, it's very hard to predict based on the timing of the last meal whether they have an empty stomach or not in these special cases. So these are some of the limitations of the guidelines, and these are the kind of cases in which I think gastric point of care ultrasound could be most useful. So the extreme ends of aspiration risk are quite clear. On the one hand, on the one end of the spectrum, over here, we have those patients who have a low risk of aspiration. They are healthy, they are fasted, they're coming for elective surgery. Their chances that they have a full stomach is very, very low, and the risk of aspiration in general is quite low. On the other hand, we have patients with clearly a high risk of aspiration. For example, if they have a bowel obstruction and they're actively vomiting, we would all consider them to have a full stomach and a high risk of aspiration, and we would treat them as such. However, in the middle, we have those patients in which the situation is not clear cut and the risk is a bit more gray. So those patients that, although fasted, they have serious comorbidities that may delay their gastric emptying, or they're coming for urgent emergency procedures. They may not even have had a chance to fast, or they may have a full stomach despite fasting. So it's in these cases in which the pretest probability of a full stomach is 50%. So, it's 50-50 rather than flipping a coin. These are the cases in which gastric ultrasound can be extremely helpful to help us turn a gray area into a black or white. The stomach is empty or the stomach is full. When we do gastric ultrasound, we concentrate on the antrum of the stomach. The antrum is the most distal part of the stomach, just proximal to the pylorus. And we assess the antrum for a number of reasons. In the first place, the antrum is very consistently located. The location of the antrum does not vary all that much, and it's very amenable to ultrasound examination. We can find the antrum in the vast majority of cases, in the vast majority of types of patients, and regardless of the type of content. So that's why we concentrate on the antrum. And most importantly, it gives us an idea of what's going on in the rest of the stomach. So even though we are assessing the antrum, our findings are a good surrogate for the content in the entire organ. So when we use a curvilinear probe in the epigastric area in a longitudinal plane in the epigastric area, we can find the antrum as a hollow viscous distal to the edge of the liver, anterior to the pancreas, and anterior to the aorta and spine. The patient position in which we perform the examination is very important. The supine position is usually an okay position to start the exam in. If we find a grossly distended stomach with lots of content, that may be sufficient to give us an answer of what's going on. If we find solid food, for example, in the supine position, that may be the end of our exam. However, if we find a small amount of content, especially if it's clear fluid content, or the stomach looks empty, we should never rely entirely on the supine position to define an empty stomach. We should really confirm that in the right lateral decubitus. The reason is that the right lateral decubitus makes the antrum become the most dependent part of the stomach, and so it's a much more sensitive patient position to evaluate more accurately the type and the amount of content in the stomach. It's much more sensitive. So when the stomach is empty completely, even in the right lateral decubitus, we may see something like this, an antrum that is collapsed. It's a first hollow viscous distal to the edge of the liver, but it's completely collapsed with no obvious content, and you can see the more prominent layer of the wall, which is the muscularis propria. This is the pancreas, and this is the aorta and spine in the deep areas. After a cup of tea or a glass of water, the antrum is going to look like this. There's going to be some clear fluid, which looks like anechoic or hypoechoic content, sometimes with a few air bubbles. Now, after a solid meal or a thick fluid, including yogurt, for example, oatmeal, that kind of thing, we are going to see the antrum that is distended and the content is hyperechoic in nature. You can see here the antrum quite distended with hyperechoic content anterior to the pancreas and the aorta. Occasionally, after a recent solid meal with not much fluid, we may see something like this. The antrum is distended. There's significant amount of air along the anterior wall. Occasionally you see some peristalsis here. You can see that there's some content there that's moving around, but most of what you see is just the anterior wall of the antrum with air. That air artifact is blurring all the posterior structures. We cannot see the posterior wall of the antrum here. We cannot see the pancreas. We cannot see the aorta very well. All we see is a dilated antrum with air along the anterior wall. And this is a very characteristic finding of a recent solid meal. So these images that we just saw are the first step in the evaluation. The first question that we want to answer when we're doing gastric ultrasound is, what is the type of content in the stomach? So the extremes here have quite an obvious clinical consequences. So for example, if the antrum looks completely empty with no content, what we call a gray zero antrum, no content in either position, we can be pretty certain that the stomach is empty, and this is a negative test for a full stomach. If we see solid content in the antrum, whether it's in the supine or right lateral decubitus position or any other position, if there is solid content in the antrum, we can be pretty certain that this is a full stomach. I think any one of us would treat a patient with solid content in the stomach as a full stomach with a potentially high risk of aspiration. On the other hand, if we see only clear fluid, we need to ask ourselves the question, how much clear fluid is there? Because a small amount of clear fluid in the order of less than 1.5 mils per kilo, it's completely normal in fasting patients, and we know carries a negligible aspiration risk. However, if we start finding a greater volume of clear fluid in the stomach, greater than 1.5 mils per kilo, this is not as common in the fasting population, and the higher the volume, it's quite possible that this could pose an aspiration risk to our patients if the volume is high. So there's a couple of different ways to evaluate volume. The first one I'm going to discuss, and probably the most accurate one, is to do a gastric volume assessment. And we do that by measuring the cross-sectional area of the antrum in centimeters square in a 2D frozen image. You can see here the antrum, the liver, the pancreas, the aorta. This is a superior mesenteric artery, and this is the spine. So we measure the area in a systematic way in the right lateral decubitus between peristaltic contractions at the level of the aorta, and including the full thickness of the gastric wall all the way to the serosa. And when we measure the area in that manner, we know that it correlates with total gastric volume. We've done some studies, including this one, that correlated in a blinded manner the cross-sectional area of the antrum in centimeters square, evaluated by a blinded assessor, and we correlated that with the entire volume that was suctioned from the stomach during gastroscopic examination under direct gastroscopic vision. And we found that there is a linear correlation between the area of the antrum and the volume in the stomach in a linear manner, up to about half a liter. Those were the volumes we studied. So this formula can also be represented in the form of a table. If you know the patient's age and the cross-sectional area of the antrum in centimeters square measured in the right lateral decubitus, you can have a pretty accurate estimate of what is the volume of clear fluid in the stomach. So if we have smaller volumes, typically with areas less than 10 centimeters square, 4, 5, 6, 8 centimeters square, these volumes are very small, and they're essentially less than 1.5 mils per kilo in most patients, regardless of their age. And these volumes are consistent with fasting, and they probably carry a very negligible aspiration risk. However, if we, have a bigger antrum down here, these volumes of 200, 300 milliliters, this is really in excess of what we would find in a fasting patient, and this probably correlates with higher risk of aspiration. Another way of estimating volume is what we call a grading system. It's based on qualitative findings alone. We are not measuring anything, and we are describing the antrum, classifying it as a grade 0, grade 1, or grade 2 antrum. A grade 0 antrum is the one where you see absolutely no fluid, no content, no fluid and no solid in either the supine or the right lateral decubitus position. And we know that these qualitative findings correlate with essentially zero volume, a completely empty stomach, and about 43% of all fasting patients present a grade 0 antrum. Now, grade 1 antrum is also a completely normal finding in fasting patients, and what this means is that there's a small amount of volume content that can only be picked up in the right lateral decubitus position, and it's negative in the supine position. This correlates, based on our studies, with a small volume of content in the stomach in the order of about 0.2 milliliters per kilo, within a completely normal range for a fasting person. Now, a grade 2 antrum is not as common in the fasting person. It is defined as a distended antrum with positive clear fluid findings in both supine and right lateral decubitus position. In this sample of patients, of 200 elective patients, we found only 3% of them had a grade 2 antrum, and in all these cases it correlated with a much higher volume of fluid in the order of 2.8 milliliters per kilo on average on these patients. So this kind of completes our picture. If we have a grade 0 or grade 1 antrum and the volume of less than 1.5 milliliters per kilo, we would consider this compatible with a fasting state and carrying a negligible aspiration risk. While a grade 2 antrum with significant amount of clear fluid, it's not that compatible with a fasting person, and there is either a delayed gastric emptying or a hyper secretion state, or a recent ingestion of fluid. So to apply all of these in the clinical scenarios, we need to have a good framework. And I really like this IAM framework that was first described for lung ultrasound, and I think it applies itself very nicely for any point of care ultrasound application. So first of all, we need to have a definitive clinical question, an indication. So no exam needs to be done in every single patient, obviously, and the indication in this case has to be a clinical doubt. When there is clinical uncertainty about gastric content, we're wondering whether the stomach is full or empty, we're not sure, and that answer, whether it's full or empty, is going to affect how we manage the patient clinically. So that is the best indication for point of care gastric ultrasound. Once we have a question, we need to know how to acquire the images, and we discussed that already. What are the right views? How do we obtain those images? And what are we looking for? When we find those images, we need to know how to interpret them. What does it mean? Is this a full stomach or an empty stomach? Is this solid? Is this fluid? Is there nothing? And if there's fluid, how much? And is this consistent with fasting? And then once we have our interpretation based on our findings, we are going to make our medical decisions or anesthetic decisions. How are we going to treat this patient? Are we going to proceed with the case or not? And what is going to be an anesthesia management like? So I have a couple of examples to discuss. The first one is an elective surgical procedure. A healthy lady, 40-year-old. She's slim, no previous comorbidities. She's coming for an elective arthroscopic meniscus repair. Unfortunately, she had eaten a yogurt, a banana, and an orange 6 hours ago. And this is certainly beyond what the ASA guidelines recommend for 6 hours. This is greater than a light meal. So we were wondering, well, is her stomach full or empty? We weren't quite sure. Can we safely proceed with the surgery, or should this be rescheduled? So with that question in mind, we acquired the images you can see here, a video clip. This was in the lateral decubitus position, but in this particular patient in the supine position, it didn't look very different. You can see there's a clearly distended antrum with heterogeneous content. This is the border of the antrum. This is the liver. It's distended. There's large particles of food. There's hyperechoic content, and there is some air content blurring the posterior structure. So it's definitely a full stomach with solid. So we decided to wait another 2 hours until 8 hours after her meal and repeat the exam at that time. Unfortunately, at 8 hours, the stomach was still full with solid content. So because this was an entirely elective procedure, we decided that it would be safer and more prudent to reschedule this particular surgery. The case of this lady is one of 38 patients that we included in these prospective study, in which we looked at the gastric content of patients like her who were coming for elective surgery, but they had only really borderline adherence to fasting instructions. So whenever there was any question about whether to proceed with surgery or not, or how to manage these patients, we added gastric ultrasound to the clinical assessment. We shared that with the treating anesthesiologist. There were 17 different treating anesthesiologists in this study. And then we documented whether the findings of the gastric ultrasound in any way changed the anesthetic management plan. And what we found is that there were changes in 71% of cases. This was actually higher than we expected. And most of the changes, given that these were elective cases, were related to the surgical timing. In other words, there was, for example, a finding of a full stomach that wasn't quite expected. So if the case was going to proceed in the face of a full stomach with solid content in the stomach, the case may have been canceled, or vice versa. Patients that were going to be canceled, if we found that there was a completely empty stomach, they would have gone ahead with the surgery. So these were the types of changes we found. And we think these type of studies are relevant and important, because if we do these point of care tests and we find absolutely no surprises, the findings are exactly the same as we expected clinically, and there are no changes whatsoever in clinical management, then there is very little value to doing these tests. But when you find surprises and it helps you to change your management, that is the classical definition and the classical uses of point of care ultrasound applications. This is another example. It's a case I had a few months ago, an 82-year-old gentleman who had had a fall at home. Unfortunately, he suffered an unstable C-spine fracture at the C5 level. He presented to the operating room neurologically intact on a hard collar to prevent any movement of the neck, and requiring an urgent C3 to C7 decompression and fusion. He had been well fasted for over 12 hours, and our plan a priori was to intubate him asleep with a fiber optic intubation after induction. However, in the holding area, he told us he was nauseous, and he vomited a small amount, about 50 cc's of, a clear type of liquid in the holding area. So the indication for a gastric exam in this case was we weren't quite sure whether he had an empty or a full stomach despite 12 hours of fasting. And the question was, is a sleep fiber optic intubation still a safe choice for this gentleman, or do we need to change our management plan? So with that question in mind, we did a gastric ultrasound exam in the operating room. And we found that the antrum of the stomach was grossly distended with lots of clear fluid content. By definition, because it was distended in both supine and right lateral decubitus position, this is what we call a grade 2 antrum with a large volume of clear fluid. The area of the antrum in the right lateral decubitus position was about 38 centimeters square, well above that threshold that I normally use of 10 centimeters square. This was well above that, and the estimated volume based on our formula and our table was greater than 400 milliliters. So given that the content was clear fluid in nature, we thought that it could be amenable to evacuating the stomach with an nasogastric tube. So we placed an nasogastric tube with the patient awake, and we suctioned approximately 450 milliliters of fluid from the stomach as expected. This was very similar volume to the one we had estimated with our ultrasound exam. After that, which now showed a completely empty antrum. This is in the right lateral decubitus. You can see here the antrum is collapsed. There's very little to no content, and we define this as a grade 0 antrum. The area was about 6 centimeters square, which for his age corresponded to a volume of about 10 milliliters. So essentially negligible, with we figured these implied very low risk of aspiration. Based on those findings, and after having evacuated the stomach successfully, then we proceeded to perform an asleep fiber optic intubation as originally planned, and this was safe. There were no incidents, and the patient underwent his surgical procedure quite well and was extubated without incidents the next morning. So you may wonder, what is the accuracy of these diagnoses? How certain can we be that a gastric ultrasound exam that shows us a positive for full stomach is indeed positive? And if it looks empty, how certain can we be that is indeed empty? So we did this study in healthy volunteers, and half of these healthy volunteers, we kept them fasted, and the other half we gave them something to eat or drink, either coffee and a muffin or apple juice. And then we had a blinded anesthesiologist perform gastric ultrasound on these volunteers and determine in a blinded manner whether they had a positive or a positive or a negative test for full stomach. So the pre-test probability in these individuals of having a full or an empty stomach was 50%, because 50% of them were indeed fasted and 50% of them had eaten or drunk something. So this pre-test probability of 50% resembles our clinical scenarios when we are not certain what the content of the stomach is. And what we found is that in this series of 80 subjects, there was a very high sensitivity of 100%. So essentially every case of full stomach was accurately detected, and a specificity of 97.5%. So there were very, very low incidence of false positives. So what this means in this Fagan nomogram is that if you start with the pretest probability of 50% and you find a full stomach on gastric ultrasound, the actual likelihood that that person has a full stomach is about 98%. So it's very, very high. And if you have a negative test for a full stomach, the chances that that person has a full stomach is less than 0.1%. So again, very accurate when it's negative. Like any other test, it has its limitations. In about 2 to 5% of cases, the exam may be inconclusive. Patients who have had previous gastric surgery, our assessment, especially of our assessment of gastric volume, may be inaccurate. Patients who have had a gastric band, a gastric bypass, or a partial gastrectomy, in these types of patients, obviously, the volume assessment is not accurate because the size of the entire stomach and the shape is different from normal. Similarly, patients who have a very large hiatus hernia with perhaps half of the stomach in their chest, our assessment in the epigastric area is going to be limited and may not be accurate. So in summary, we have discussed how to use ultrasound at the bedside to assess the gastric content. We talked about using this I-AIM framework to guide our clinical thinking and to guide our assessment and medical decision making. We reflected on the fact that the ultrasound assessment has both a qualitative and a quantitative component. And we discussed a couple of examples of how you can apply gastric ultrasound both in elective and urgent situations when the gastric content is uncertain. We talked about our literature on what the diagnostic accuracy is of these type of tests, as well as discuss some limitations. For those of you who are interested in learning more about gastric ultrasound, I highly recommend you check out this website, gastricultrasound.org, which has plenty of pictures, images, and videos on gastric ultrasound, and it's very illustrative. As well, the American Society of Regional Anesthesia, among other societies, has some really good courses of introduction to comprehensive point-of-care ultrasound that includes gastric ultrasound assessment, heart, airway, lungs, and FAST, and I highly recommend it. And the American Society of Anesthesiologists has recently come up with a first certificate of completion in diagnostic POCUS program. It's been quite successful. We have close to 1,000 participants already in the program in the first year since inception. And again, you may want to check it out if you're interested in receiving certification in point-of-care ultrasound. And with that, I want to leave you with a quote, a phrase that I find highly inspirational for those of you who want to push the limits, who want to come up with innovative and creative solutions to our existing problems. And Margaret Drupal once said that when nothing is sure, everything is possible. Thank you very much for your attention.
Great. For both of you, congratulations, Drs. Perlas and Dr. Chan, for that very, very informative webinar topics, and that were so perfectly delivered that we are now teeming with queries from the 1,200 participants that are raring to know more. Now, it's nice to see you again, Dr. Chan. The last time I had a chance to work with you was in Thailand in 2018, pre-pandemic. And it's also very nice and an honor to meet you, Dr. Perlas. How's the weather in Toronto, Canada nowadays?
Snowy.
Oh.
Snow is -7 today.
Okay, we envy you because it's getting warm here in the Philippines. However, in spite of the weather getting warm, the COVID numbers are going down in our area. That's a very, very good news for us. How about in Toronto nowadays?
Same
It's
thing.
also
Same
going
thing.
down, yeah.
Great. That's great news, sir. Now, and ma'am, very nice to hear. To start the ball rolling, I would like to field the questions on an alternate basis. We start with ladies first, definitely. So we're gonna ask. I'm going to ask Dr. Perlas. There's a question here. Is there a study done on pregnant patients? What is the best way to perform a gastric ultrasound? And then another correlating question is, does the gastric volume determination correlate well in pregnant patients? Is it done differently, like in positioning, because they obviously have a very big tummy? And how about if we're doing it in patients who are actually in labor? Is the gastric contents affected by that? Dr. Perlas?
Yes, thank you. Those are excellent questions. There are quite a few studies performed on pregnant ladies. There are quite a few studies, for example, from Toronto, a colleague of ours, Dr. Arzola. He's published several papers in this area. There's also the group in France, led by Dr. Bouvet, who's also done a number of studies in pregnant ladies. And there's a couple of things that are a bit surprising. We found in pregnant women that are coming for elective C-section at term, the amount of gastric content doesn't seem to be any different from non-pregnant people. The gastric ultrasound exam is done in a very similar manner to non-pregnant patients. And the distribution of these grades that we described, grade 0, grade 1, grade 2, in terms of what proportion of patients have these grades is very, very similar to non-pregnant people. We feel it's different once labor has started. It's been very well established that labor affects gastric emptying, and it's very unpredictable once labor starts, whether the stomach is going to be empty or it's going to be full. So in fact, it's in these patients that are in labor where gastric ultrasound may be most useful to decide what's the situation and what you're dealing with.
That's great. That's a good information to anesthesiologists who are doing obstetric procedures. If I was in their shoes, I would be so occupied already with treating the patient and in full labor that I might not focus more on how much the gastric content is. But that's a really great answer. Dr. Chan, is it obviously this is a question that came from somebody who's doing thoracic procedures. Is it possible to check the placement of a double lumen tube, the one they use for selective ventilation for thoracic surgeries, through the use of ultrasound?
Yeah, there are a number of studies published, and again, they're using the pleural sliding. So looking at the ventilation. So if the side that is ventilated, obviously the pleural sliding will happen. On the side that is not ventilated, you don't see the lung sliding. But again, I find that lung sliding, because it's a fine movement of the pleural line, sometimes I find that it's not so easy to pick up, particularly when you're ventilated the patient, as opposed to asking the patient to take a deep breath in is more dramatic. So I find that a gross movement of the pleural line using either linear or curved probe on each side of the chest wall and look at the descent of the pleural line. On the right side, going down towards the liver, on the left side, going towards the spleen. I find that is very, very helpful to tell. So yes, mainly double lumen tube is the side that's ventilated, you will see movement.
That's great, sir. Given Dr. Perlas, given the high sensitivity and probability of the test for looking for gastric contents, how accurate is gastric ultrasound in estimating contents on an interval basis, maybe to monitor gastric contents prior to doing an emergency procedure, as was mentioned in one of your cases that were presented? Can we rely this much on this protocol for surgical procedures? I mean, if I can do it and then say to the surgeon, oh, we gotta cancel. This patient ate a lot of peanuts today.
Well, thank you. That's exactly how we feel that these can be used. And I'd like to reiterate the concept that not every patient needs to have an ultrasound of the stomach, obviously. It's only in cases in which clinically there is doubt because there is no information about when was the last meal, or there is a language barrier, or there are conflicting information. Somebody says they ate, but there's other information that says they didn't eat. Or like the patient we had in the example, they are supposedly fasted, but they're nauseous and they're vomiting. So there's contradictory information clinically. So in these gray areas is where we find gastric ultrasound is very useful. It's being used more and more. It's being embraced in many parts of the world. And just last month, we had the first guidelines, fasting guidelines from the European Society of Anesthesiologists for Children that suggest that when this is the situation, when there is clinical uncertainty about gastric content, they highly recommend in the guidelines that gastric ultrasound be used specifically for this purpose to determine is the stomach empty or full, should we proceed, should we cancel, and how should we manage the airway of the patient.
Thank you, Dr. Perez. You just reminded me of one sneaky patient of mine recently who never told us that she had a bite to eat, so we had to delay it. Only the relative admitted that she saw the patient eat a big cookie and a glass of milk. So that would be beneficial looking back, the use of the ultrasound. Dr. Chan, this question is for you. You mentioned that the curve probe can be used for an airway examination. In relation to this, because in my practice, the one who's asking the question, I usually use the linear probe. In what instances can the curvilinear be used?
Again, for me, I usually use the linear probe as well. As I said, most of the airway structures are superficial, very, very superficial. So a linear probe makes sense. The time you will use a curve probe is you want to have the full view of, let's say, the submandibular area. So right now, when we're doing assessment of the tongue thickness, the base of the tongue, you can see a complete view from the mandible all the way down to the larynx, to the hyoid bone or below. So that's the time you would use a curve probe. You see the full view of that area. But most of the time, I just use a linear probe for the assessment. It's a much better resolution.
That's great, sir. Dr. Perlas, this one is quite sensitive because it's asking about skill. Is it possible that vigorous manipulation of the stomach by an amateur ultrasound operator predispose an unexpectedly full stomach patient to aspiration?
Well, the idea is that we perform these exams with the patient awake prior to giving any anesthetic and prior to making any decisions. To be honest, in my practice, I haven't seen that happen yet. I have scanned many, many times patients with full stomachs, and I've never experienced that doing the exam caused any regurgitation or any vomiting. I suppose the patients may vomit anytime, may regurgitate at any time, even during the exam. If that is the case, again, we are performing the exam in an awake patient, so they have their protective mechanisms intact. So, yeah. So there shouldn't, that shouldn't be the case.
Well, that's good. I'm also an amateur, so I'm affected by that question. Now, Dr. Chan, can we use the diaphragmatic excursion as a criteria for extubation in the OR?
I have never tried that. I don't know what type of patient I worry so much in the operating room to decide whether extubation is successful or not. I mean, if someone is really a respiratory cripple, most likely that patient will be intubated before coming to surgery. So I have not done that. I know that people in the ICU have looked at diaphragmatic thickening as a criteria for extubation, for prolonged intubation and ventilation. But in the operating room setting, I have never tried that. I have never seen, I don't think I've seen a study looking at that. But the first question I ask is, what type of patients would I apply ultrasound to look at the excursion, diaphragmatic excursion, and what patients I worry about extubating them? Because of respiratory, obviously, is the diaphragmatic paresis or weakness.
Yeah. Likewise, Dr. Chan, I've seen a lot of research and practice on critically ill patients in the ICU that they're doing this predictive maneuvers for extubation, but not in the operating room. Dr. Perlas, I would like to ask, what patients do you find difficult to acquire views of the stomach, and how did you address it if you are encountering difficulties?
It's a good question. The most common thing is that the stomach may be quite high and may be hiding behind the lower part of the thorax, let's say. And in order to have a good view of the stomach, we also need to see the liver to confirm that the organ we're looking at is the stomach. So I often ask the patients to take a very big breath, take a big breath and hold it there. And then when I do that, usually the liver obviously comes down because it's being pushed by the diaphragm with the big breath. And by the liver coming down, it makes the stomach more visible. So this is the number one common difficulty that I find, that it's easily addressed. The other group of patients is morbidly obese patients. The antrum may be deeper, so it may be a little bit more difficult to see. Again, usually positioning the patient correctly, asking them to take a big breath is very helpful. And despite being morbidly obese, we find that it's feasible to find the stomach in about 95% of morbidly obese people. So it's not, you know, that difficult, but a bit more difficult than the average patient. And then it's the pregnant ladies is the other group. And sometimes if it's difficult to position the patient in, for example, in the right lateral decubitus, when they are at term, when they're pregnant, you may use the semi-recumbent position, so half sitting with the head elevated 45 degrees. That position is also helpful, and it may be sufficient to, you know, find an answer to your question.
Thank you, Dr. Perlas. Now, Dr. Chan, may I ask how to assess cricothyroid membrane for emergency cricothyroidotomy in a difficult intubation when no prior mark was done? I mean, if you run out of paper clips.
So are you asking, you try the intubation, now you're in an emergency situation,
In an emergency.
now apply ultrasound?
Yes, sir. If there was no prior marking that was done.
Yeah, no prior marking, and you cannot palpate, you cannot find the cricothyroid membrane.
Yes.
Then the first thing is you pray, you ask for help. You obviously need to get someone to get your ultrasound in quickly and find it. And as I said, I don't advocate that we use ultrasound to locate the cricothyroid membrane in every patient, but it would be very useful to practice in patients with a normal neck anatomy, right? If we don't know how to do that in an easy airway situation, then difficult airway situation will be tremendously, it will be a disaster. So practice, get used to seeing it. Then in an emergency situation, you will be much better off.
Simulation and practice makes perfect. That's aptly put, sir.
Just like fiber optic intubation, right? You want to learn that in someone that is an easy airway before you try on a difficult patient.
Dr. Perlas, thank you, Dr. Chan. Dr. Perlas, as was asked with Dr. Chan, that the question about using ultrasound as a guide for extubation. There's a question here about the value of ultrasound-guided visualization of the stomach and its indication for the removal of an existing nasogastric tube and the indications for gastric feeding. Can it be a tool to aid decision-making for gastric mobility, safety, and aspiration precautions?
Yeah, thank you. I haven't seen very many studies published in the anesthesia literature per se, but there's a growing number of publications in the ICU setting looking exactly at that issue. Can we use gastric ultrasound to give us information about how the patient is tolerating their feeds? We know that in ICU, there's a fairly high proportion of patients that have ileus, that have delayed gastric emptying. And there's always the question whether they are tolerating their nasogastric feeds or not. So I think there's a growing body of evidence that says that it can be useful. And again, there's a specific information about that. And I think that's an area where this can be potentially useful to decide, is the stomach full or empty in that setting.
Thank you, Dr. Perlas. That's very helpful, that answer. Dr. Chan, I've seen you lecture and do this on a convention, but somebody's asking, based on the studies, interscaling block can cause hemidiaphragmatic paralysis in 99% of the time. In your experience and observation when using the ultrasound, is this true?
Yeah, it's true. A few things have changed, right? The studies by Bill Ermey, when he looked at the diaphragmatic paresis after interscaling block, much bigger volume of local anesthetic was used. Now we tend to use a smaller volume. In our center, we use between 10 to 15 mils of local anesthetic for an analgesic interscaling block, as opposed to a surgical block. So, but if you scan the diaphragm before and after the interscaling block, you will see diaphragmatic paresis. Some are partial, some are complete, and you see some even have paradoxic movement of the diaphragm. But what is, I think, while it is true that the hemidiaphragmatic paresis does happen quite often after interscaling block, very few patients become symptomatic. And so one thing is true, there is phrenic nerve block, partial or complete, but on the other hand, few patients will become symptomatic after the block. And recently, I'm just asking myself, have I ever seen patients who become short of breath or have oxygen desaturation after interscaling block alone? I must say, from my observation, I have not seen it. But I've seen patients who have trouble breathing and have oxygen desaturation after the general anesthetic, after the shoulder surgery. So my thought is that perhaps the combination with the hemidiaphragmatic paresis and now with after general anesthesia with atelectasis, and now with the tube hit, maybe now we are seeing the problem. This is just my theory. It will be time we can do the study and look at that.
Thank you very much. We're down to two more questions, one each. Dr. Perlas, this is a question. Would you say that only certified POCUS trained anesthesiologists should do gastric volume assessment? Is that a requirement?
That's not a straightforward question to answer. I think it depends on your practice setting. I know in some countries, for example, in the United States, for anesthesiologists, it's very important to be certified, to have permission from their own hospitals to perform certain things, like perhaps gastric ultrasound and other point of care applications like heart or lung. So it depends on your practice setting. In Canada, for example, we do not have that requirement, and it is accepted if physicians consider that they are properly trained, that they have undergone sufficient training, and you feel that you are confident in your abilities, then it's accepted that you don't need a special certification. So that really depends on which country you're practicing and on what are the local customs, what is accepted locally.
Thank you very much, Dr. Perlas. For the last question for Dr. Chan, are we in a stage where it is better to do a real-time assessment of the endotracheal tube in the trachea versus the double trachea technique where it relies on the endotracheal tube in the esophagus? It's like an all or none question. If it's not there, it's in the other tube. So which do you prefer as a verification method?
Well, I thought about this quite a bit, and it's fun to do studies, it's fun to look at different applications of ultrasound, but I ask myself, if I really worry about the tube placement, would I not just look at it directly, particularly now if you have video laryngoscope, right? It's so easy to look at the larynx. Would I not visualize it directly as opposed to using the ultrasound? If you can use it to just for fun. To me, it's like for fun to see what the endotracheal tube placement looks like. If you want to do a real-time visualization of the endotracheal tube placement during intubation, it's not easy, because if you put it right over the trachea, as you know, when we intubate, we extend the head and trying to now compete with the laryngoscope, that will be is not easy to do. So after, and also if you are looking at it real time, all you see is a flash. You see something very quickly go through the trachea, and that's all you see. And oftentimes you will miss it. Now, after the intubation, yes, you can put the probe on each side, look at the esophagus and see if there is a foreign body there. If there isn't, then you assume it's in the right place, or you blow up the balloon and look at the tracheal dilatation test. So all those things can be done. But if I ask myself, which technique, method would I use to verify the tube placement? If I can see, I definitely would now use a video laryngoscope.
I agree. I agree very much, Dr. Chen. Now, thank you very much for spending your time with us and giving us very, very valuable insights on POCUS, on the airway and gastric visualization under ultrasound. It was indeed very informative, and I'm sure a lot of our attendees, more than 1,000 of them, are now raring to go back to their hospitals, open their ultrasound, and probably look at all their patients and see their stomachs and predict the size of the tube that they're going to use for intubation. To wrap up the session for today, I turn you back to Dr. Pen Cano for some messages. Thank you very much, Dr. Chan and Dr. Perlas.
Thank you for having us.
Thank you.
So, on behalf of the Manila Academy of Regional Anesthesia, we are going to present this certificate of appreciation to Dr. Vincent Chan and Dr. Anahi Perlas in grateful recognition and appreciation as speaker. The topic for Dr. Vincent Chan, application of airway ultrasound. For Dr. Perlas, the topic on gastric ultrasound, assessment of gastric content and volume. We had a very productive evening. So on behalf of the Manila Academy of Regional Anesthesia, let me thank once again Dr. Chan and Dr. Perlas for the very excellent lecture. Especially, we would like to thank both of you because we started at 6 p.m., which is 5 a.m. in Toronto, which is a very unholy hour. We would also like to thank Delex Pharma for making this webinar possible. And last but not the least, let me thank, on behalf of Mara, all the attendees, 1,300 of them, for tonight's webinar. But before we end, let me remind everyone to answer the questions and also the evaluation before you leave the webinar for tonight, for you to be able to get that certificate. So let me greet everyone a safe weekend. Good night, and thank you.
Thank you very much. Thank you.
Bye.
Bye.
Bye-bye.
Thank you, Dr. Perlas and Dr. Chan. Have a safe day.
Dalex Pharma International is a Filipino-owned and managed pharmaceutical and medical device company with the aim to bring affordable and quality medicines in the ICU setting. Home of Dalex ICU Forum, a train-the-trainers program to raise the standard of critical care practices. Your prescription doesn't just save lives, but they transform lives to our CSR program. Care LGL and Dalex Pharma introduce NutraClear, a completely transparent neutral displacement connector that prevents catheter-related bloodstream infections. Its exclusive design guarantees that best practices are followed and ensures patient safety. NeutraClear's smooth, flat septum makes it easy to disinfect. The guiding seal ring protects needleless connector's integrity. Its 2.8 centimeter size and 1 gram weight reinforces care comfort in neonatology and pediatrics. The neutral displacement design prevents blood reflux in the catheter. Thus reduces the risk of occlusions and infections in the catheter. Its completely transparent needleless connector ensures best hygiene practices and is recommended by experts for effective flushing. NeutraClear, the closed system which guarantees neutral displacement and complete transparency to prevent catheter-related bloodstream infections. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage, according to the International Association for the Study of Pain. Pain is such an important indicator of health. Its assessment has been called the fifth vital sign, joining temperature, pulse, respiration, and blood pressure. Pain is one of the most common, debilitating, and feared symptoms of cancer. While labor pain is the most undesirable and unpleasant aspect of labor experience during childbirth, there is a need to strengthen preventive strategies for effective cancer pain management and labor analgesia, as these has the significant impact on the quality of life of the patients. Dalex Pharma International Incorporated and Smiths Medical understands these unmet needs, thus are proud to introduce CAD Solace, advancing labor analgesia and pain management care in single infusion platform. The CAD Solace system with PIB delivery along with PCA, a state-of-the-art smart pain management system for better pain management for labor analgesia. PCA, and PIB deliveries combine to create more effective drug delivery duration and block density, supports latest clinical research findings for programmed intermittent bolus deliveries. CAD Solace is a multi-therapy smart infusion for home care. CAD Solace is safe, simple, and smart, compact, lightweight pump designed for patient mobility. CAD medication cassette reservoirs are designed to keep medication safe and secure. Large screen differentiates therapies and displays infusion settings. Scroll keys help prevent double key press errors. programming limits, clinical advisory notes, and best practice protocols. Smart pump technology promotes patient safety. CAD Solace advancing labor analgesia and pain management care in single infusion platform. You may ask our hospital representative from Dallas Pharma International Incorporated, assigned in your area with regard to CAD Solace.
Sepsis, a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis and septic shock are major healthcare problems, impacting millions of people around the world each year and killing between 1 in 3 and 1 in 6 of those it affects. Shock is common in critically ill patients with COVID-19, developing in up to 67% of patients in intensive care and is associated with high mortality. In the recent guidelines issued on care of critically ill adult patients with COVID-19, norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. But sepsis and COVID-19 do not only affect the health of the patient. Sepsis and COVID-19 can cause financial burden and has an impact in the environment as well. Although there are positive effects brought about by the lockdown, there is a growing concern in the increasing medical waste generated from hospitals and public's use of disposable safety equipment. brought about by sepsis and COVID-19, there is a need for an ideal norepinephrine solution to manage hypotension due to shock to achieve mean arterial pressure greater than 65 mm per mercury. A cost-effective norepinephrine to help alleviate financial burden, a norepinephrine that cares for the environment. Norepin is an ideal norepinephrine solution based on clinical studies and guidelines. Norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. Norepin passed the Institute of Pharmaceutical Sciences National Institute of Health in UP Manila with an assay test result of 106.7%. Norepin is cost-effective compared to the Innovator brand and can provide a savings of up to 23,000 pesos. Norepin 10 ml preparation can cut the number of ampules to be opened by 40% compared to the Innovator brand. Thus, it helps lessen the medical wastes. Moreover, Norepin 10 ml preparation has the following advantages. Be a part of our CSR advocacy and world vision. Your prescription doesn't just save lives, but transform the lives of these children in world vision. Every time you request Norepin at the pharmacy means sending a child to school and help fulfill their dreams.
Pain is the most common reason people seek medical care. In the postoperative period, 80% of individuals suffer from postoperative pain, with almost all describing it as moderate to severe. The ERA's protocols recommend the use of preemptive analgesia and NSAIDs as postoperative analgesic to decrease opioid requirements. NSAIDs are also proven to be effective in the management of acute pain with an inflammatory component and as part of multimodal analgesia. But not all NSAIDs are the same. For better pain management, use an NSAID that is safer, tolerable, and effective. Studies proved that ibuprofen's adverse effect profile is better since the COX-1 and COX-2 ratio is lower. This is the reason why ibuprofen has been rated as the safest conventional NSAID. In a meta-analysis where the gastrointestinal risks of 28 NSAIDs were compared, ibuprofen possesses one of the most favorable risk profiles at 1.8 compared to diclofenac at 3.3 and ketorolac at 11.5. Ibuprofen was also found to be one of the molecules with low cardiovascular risk. There were initial concerns about the safety of people with COVID-19 taking ibuprofen. The WHO conducted a comprehensive review of 73 clinical trials on the safety of NSAIDs for individuals with COVID-19 in 2020. They found no evidence between taking NSAIDs and severe side effects, reduced recovery times, or death in people with the disease. A more recent study in the United Kingdom also found no evidence of an association between NSAID use and a higher risk of death or more severe illness in those with COVID-19. IV ibuprofen also reduces opioid doses. In a clinical study, patients treated with IV ibuprofen used 31% less morphine following orthopedic surgery. IV ibuprofen's efficacy is evaluated in this Oxford League table, where the number needed to treat or NNT values of various analgesics are compared. Ibuprofen 800 mg and 400 mg have lower NNT values of 1.6 and 2.4 respectively, compared to other analgesics. Intrafen is the first and the only IV ibuprofen in the Philippines. Ibuprofen, Intrafen, has 3-in-1 benefit. The pain-relieving properties of Intrafen relate to its central and peripheral effects. Apart from being an effective postoperative analgesic, ibuprofen, Intrafen, is also good in preemptive and intraoperative analgesia. So, for better pain control, use an NSAID. That is, safer, tolerable, and effective. Use ibuprofen, Intrafen, A classic ibuprofen reinvented.
The world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share, every second counts. Live integrated tele-ultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated tele-ultrasound collaborative platform. Philips Lumify. Integrated tele-ultrasound, powered by React's collaborative platform. Innovation and you, Philips.